Of course, we talked mostly this afternoon about AMH as an excellent quantitative biomarker of ovarian reserve, as well as to expect stimulation response. But according to me, AMH still very bad qualitative biomarkers to predict anything, to predict embryo quality, to predict conception. So the question is, it's possible to have biomarkers to make both predict quantitative ovarian response as well as qualitative embryonic quality. So, I don't know which one. So the question is how to optimize IVF results. I would like to share with you. You agree with me? What do people think about when you say IVF today? So unfortunately, during the 90s and 2000, you know, this image connected with IVF. But you agree with me today, with single embryo transfer, that is the only way to prevent multiple pregnancy. For me, this is not success, but it is failure, Second point is, if you're looking by, as I did in retrospective study in my art center, so if we're looking here, the proportion leading to delivery, for me, delivery is the only way to define IVF success. So around 10% of follicle leads to delivery, 15 of all embryo, 20 embryo on day 3, and 40 of blastocyst on day 5, on day 6. That means what might explain the high failure rate. So this explains why, if we're looking in terms of the probability that which egg leads to one live birth, less 10% for collected of oocyte result for live birth for ladies, less 36 years, and only less 10% of oocyte retrieved resulted live birth for lady over 40. So why all this stage? It's because probably may explain by defect to identify competent embryo selection, abnormal endometrium receptivity, keeping in mind intercourse. For certain patients, we can alter endometrium receptivity, and probably third one, defect in embryo endometrium dialogue. So, and another point is you have to know actually in IVF lab, you have around 200 factors that you have to check permanently. So you can see air quality, handing medium, handing dish, pipettes, warm surface, luminar, microscope light, culture medium, etc., etc. Please keeping in mind 200 factors that you are obliged to check if you would like to stabilize your IVF success. It's because before to improving anything, you have to stabilize your result and to offer the same quality from January up December. Otherwise, if your result like this, like LH pulse, you cannot offer the same quality for all your couples. So, with the arrival of new emergent technologies, what we consider it omics, like proteomics, transcriptomics, genomics. So for us, it was the opportunity to use this new emergent technology to try to optimize our IVF success. So, and in certain time, random law, we did decided in my group to make sequences, very high sequences of oocyte and granulosa cells. I honestly, by unexpected way, we identify molecules which are considered as circulating. For this reason, we decided to be interesting about cell-free nucleic acids, like cell-free DNA and like microRNAs. Why we they decided to understanding about that is, remember, during the last decade, two medical Nobel Prizes. First one, 2006, about microRNA, and second one about 2013. What does mean microRNAs? MicroRNAs is a very small fragment of RNA, no coding for protein. And during many times we neglect this microRNAs because we did not understand what to serve. And the first medical Nobel Prizes, 2006, tell, yes, this microRNA, no coding for protein, and regulate gene expression. By this, we are healthy or we are ill. And second Nobel Prize is 2013 to tell there is two ways of transportation for microRNAs, free microRNAs, or transported by vehicles that we called it as cargo. That means we are interested about cell-free DNA and microRNA. One, it is causes like microRNA, and second one, like is consequences. So I will summarize my talk today, and I would like to, we are in genomic medicine today, and we try to apply this very power and very precise tool to understand about, to evaluating and to predict ovarian stress, not ovarian response, as Yuan mentioned in his talk. Second one, to predict ovarian response for IVF and ICSI, to select viable embryo and deploy, and to determine what's the best timing to replace embryo by determining implantation window. And as you know, today it's mostly largely in the world about non-invasive prenatal test by only just blood and to detect fetal cells in the blood. So let me show you about, are we able to predict about ovarian stress during cause protocol, whatever? So this is circulating nucleic acid, should consider as biomarkers in human pathologies. And if you're looking now in cancer area, these tools, it's daily used to adjust the treatment for each patient, to adjust during the disease, after the treatment, and the follow-up of each patient. We can using microRNAs and cell-free DNAs. By combining both, we are able to adjust the treatment. So cell-free DNA is not new for you. This is double standard molecule, short or long fragment, according if cell-free DNA comes from apoptosis cells or comes from necrosis cells. And circulating microRNAs, this is single-stranded molecules composed between 19 up 25 nucleotides, and two mechanisms to release by regulate the gene expression and inhibit protein traduction. Of course, microRNA, it's due to active secretion by cells, and cell-free DNA to issue apoptotic or necrotic cells. So, and by looking short or long fragment of cell-free DNA, we are able to know if cell-free DNA for healthy patients that we're supposed to take in charge for IVF baby, we are able to know if cell-free DNA comes from apoptosis or necrosis by evaluating in the serum. The question is, Yuan mentioned in there is 25% of variation inter-cycles for the women. The question is, all cycles, are we able to stimulate? So actually what we're doing daily in the true life, you start in course protocol, and on day 6 or on day 8, you decided to stop or to continue. So, but you already consumed around €800 of gonadotrophin. The question is, Yes, today by quantify cell-free DNA, we are able to cancel or to start cause protocol today before to consume 1 ampule of gonadotrophin. So if you're looking here in many gynecology pathologies, in ovarian cancer, in breast cancer, in endometriosis, in BCO syndrome patient, in premature ovarian failure, as you can see here, you have many microRNAs which are upregulating, which are downregulated. You can using, for example, in endometriosis, should we make a surgery or should we treat before to make any surgery? It's enough to quantify microRNAs that you already known. So, but as I ask my question to Johan, in certain situations we have a discrepancy between AMH and intrafollicular count. Of course, we did start to standardization as the president speakers told, but up recently there is no standardization about AMH. And as it mentioned by President Speaker, AFC operator dependent, and which cause protocol, and it is possible to predict cause protocol. Yes, I advise you to read the Lamarca paper 5 years ago about the possibility and the limit of ovarian reserve testing with AMH and intrafollicular count. Yes, we need today identification of new biomarkers of ovarian reserve and ovarian stress as companion test, not diagnosis test, but we have to consider as companion test. Once again, in cancer area, there is a lot of companion tests. What does mean? That means the value help you to take a medical decision. So you can evaluate in follicular fluid or in the blood. By this way, you can get a companion test, may help you in case of discrepancy or you are not sure relate AMH value or AFC number. If you're looking here, for example, the comparison intrafollicular cell-free DNA level according Ovarian Institute, this is normal responders patient. This is ovarian reserve disorders, PCOS or premature ovarian failure. As you can see here, in case of ovarian reserve disorders, the cell-free DNA level is much higher and significantly higher comparing with normal ovarian patient. Once again, if you're comparing between PCOS patient and normal ovarian reserve, once again, in PCOS patient presenting high level of cell-free DNA. That means if you're comparing today between PCO syndrome patient with premature ovarian failure, both are common, but imagine the mirror with two faces, one for premature ovarian failure and second one for PCOS patient. So, and by this way, we can understand why both presenting in follicle very high level of cell-free DNA comparing with patient presenting normal ovarian statue reserve. If you're comparing, once again, cell-free DNA according intrafollicular count, less 10 and plus 10, once again, when you quantify less 10 follicles, antral follicles, once again, this explain, this presenting a high quantity of cell-free DNA. And even we did try by comparing less 1 of AMH nanogram or more or less 2, once again, there is a negative and independently correlation between cell-free DNA and AMH. When AMH is very low, cell-free DNA is very high, and vice versa. Now, how about microRNA? Once again, looking here, for example, we can predict for PCOS patient by combining 3 microRNA to detect and as well as for low ovarian response by combining 2 microRNA to know exactly which kind of tools, these tools maybe we can use to predict ovarian stress. This table summary for you, when you're comparing premature ovarian failure or insuffisance, comparing with PCOS patient, either in the serum or on follicular fluid, as you can see today, you can get a lot of microRNAs, maybe help you to distinguish exactly and to know really we speak about pre-ovarian mature failure or pre-ovarian mature insuffisance or both, etc., etc. How about predicting ovarian response for IVF and ICSI? Once again, we did look for cell-free, quantified cell-free DNA according follicle diameters during course, between 8 up 12, 13 up 18, and over 18 millimeter. Once again, in mature follicles, the quantity of cell-free DNA is significantly lower comparing with small follicle between 8 and 12 millimeters. Here we did not take in account if the follicle provide or not oocyte, whatever, mature or immature. But here we just only take in account the follicle provided egg. It's because both in this study we did perform pickup by one, not mixing all follicles. And by this way, we can confirm this trend. That means the mature follicle provided eggs presenting low quantity of cell-free DNA comparing with small follicle diameters. If you're looking now according to the number of days of stimulation, of course, when you are not satisfied of cause response, what we're doing mostly, we continue stimulation. Of course, you will collecting probably one egg more, but please keeping in mind you can provoke high quantity, significantly higher of cell-free DNA comparing when the stimulation lasts 10 days. Once again, if looking according to the number of eggs, less 6, whatever mature or immature, and more 6, once again, when you have very poor ovarian response, in this way, this oocyte providing from a follicle containing high quantity of cell-free DNA. And now if the total doses of FSH, once again, when you are over 3,000 units of FSH, of course, you can collect more eggs, but once again, you can induce more cell-free DNA. Please, my message is use not more than 300 units per day. It's honestly today, doesn't make sense to go for 450 or 600 as from time to time I see from in certain centers. So, how we can explain high cell-free DNA level in follicles for patients presenting PCO syndrome or low ovarian reserve? For PCO syndrome, the increasing this explain results increase of apoptosis process in follicle due to hyperinsulinemia and defect of follicle maturation. How about low ovarian reserve? This means accelerated of apoptosis process and the effect of strong and long stimulation by gonadotrophin when you're going over 10 days and over 3,000 units per cause. And so briefly about this part of my talk, by quantifying cell-free DNA in follicular fluid, you get a diagnosis tool to predict biomarker in IVF process. To determine ovarian reserve disorders, concerning follicular maturity abnormality, to when you are in long infertility duration, long and strong stimulation, poor embryon quality, and poor ovarian response. Of course, by this way, we are able to predict a clinical pregnancy by negative effect on the conception by only 25 cell-free DNA in follicular fluid. How about the selection of haploid embryo and viable embryo? So, if you remember now, the trend for single embryo transfer, this is good practice today. Please forget 3 embryo or more, and even double embryo transfer. If you have to consider, we have more data. When you replace 2 embryo, one is good, you consider as good quality, and second one, it's medium, it's low quality. This one probably alter the dialogue between the good one and endometrium receptivity. In this way, honestly, ought to replace single embryo transfer, whatever the age, whatever the situation, it's much better to replace to one by one. In addition, today with vitrification process, you are able, I suppose, to guarantee for your patient the same success rate by comparing fresh versus deferred embryo replacements. So, a couple of slides about pre-implantation genetic screening. You have all technology today, from more expensive up very cheap today. SNP array, CGH, new generation sequencing, quantitative PCR, ingest, etc., etc. Whatever, if you screening, you make embryo biopsy on day 3 or in day 5 or day 6. You know this slide, I think most of you relate the percentage of embryo which are aneuploidy. Of course, the percentage, it's increasing with the age. I think this is evidence that we have to integrate today when you decided to including patient over 40 or 42, and this information should be given to the patient. So now, I don't know, is transferring an haploid embryo clinically is useful? Yes, once again, this is a recent study by selection single plus substitute for fresh embryo transfer. This is a condition of randomized controlled trial. The age of patient, the 2 arms, one with RA-CGH, second one with control. And once again, if you're comparing between with screening or without screening, the clinical pregnancy as well as ongoing pregnancy, it's significantly higher when you're performing BGS comparing with no BGS. So, and once again, today you can screening for monogenetic disease, and in the same way you can establish in the same sample the aneuploidy rate. I recommend for you this lecture, recent paper from Belgium group in Nature Review Genetics. So, of course, if you performing BGS, you can eliminate the impact of maternal age. Looking here, for example, percentage of miscarriage, this is in green, according to the age, and in blue without no BGS. As you can see, for no BGS, the prevalence of with stage is more here for advancing aging comparing for patient less 35 years. Once again, implantation rate, you can guarantee the same possibilities by screening for pre-implantation screening, whatever the age of patient, comparatively with patient who did not benefit of pre-implantation screening. So, but we have to consider some disagree with BGS. And the first paper in 2007 in New England Journal from Netherlands team, Matzenbroek. Once again, Matzenbroek mentioned all embryo selection techniques are detrimental, inappropriate to use implantation rate as an endpoint. It can be questioned whether all patients will ever be able to understand all of complexity concerning pre-implantation genetic screening. Cost effectiveness is being forgotten. So briefly, today there is, at my knowledge, I think 4 or 5 randomized study, and the conclusion is clear: there is no any benefit for BGS. However, I don't believe we have to subject BGS for all couples and for all patients. We have to decide and to determine which kind of profile of patient for who we have to subject BGS and which one don't need that. So I don't believe we have to subject for all. For example, BGS uses today in United States, this represent about 20% of cycles. I think so, more, as Fadi told me, more. In UK, for example, less 5%. In my country, it's not allowed for BGS. BGD, it's allowed for severe genetic disease, but it's not allowed up to date for pre-implantation genetic screening. So, another question is, why aneuploid embryo does not implant? It's because, as you know today, the best result today worldwide by using BGS, we still around between 40–50% live birth. It's a huge, it's excellent, but not 100% by replacing euploid embryo. It's because 1/3 of euploid embryo fail to implant. It's because probably it is euploid, but is not viable. So the question now, we have to combine between euploid embryo with viable embryo. So the quantity of mitochondrial DNA was significantly higher in embryo from older women. Mitochondrial DNA level were elevated in aneuploid embryo, independent of age. Blastocysts that successful implanted tended to contain lower mitochondrial DNA quantities than those failing to implant. Abnormal mitochondrial DNA levels are present in 30% of non-euploid embryo, but are not seen in embryo forming a viable pregnancy. Briefly, you have to take in account euploid embryo with viable embryo by quantification mitochondrial DNA. So we're looking circulating cell-free DNA according embryo on day 3 as a viable test. Here, according embryo grade 1, grade 2 versus grade 3, grade 4. Once again, the embryo issue from eggs, which coming from follicles in which the cell quantity, cell-free DNA level is more higher, the probability to emerge embryo bad quality according morphological aspects is much higher. Here you have cell-free DNA according to the number of cells of embryo on day 3, and here according fragmentation percentage. And of course, as I told you, by quantify cell-free DNA is associating to predict clinical pregnancy. You have the specificity, the sensitivity and specificity, and the surface curve around 0.73. And also you can screening for microRNA in follicular fluid to predict expanded blastocyst or to predict clinical pregnancy. It's because for certain situation, we are hesitating to subject for this patient long embryo culture, or we prefer to replace on day 3. So another way to identify viable embryo by screening for gene expression in any cumulus cells. In my team, we identify molecular signature by which we are able, by a non-invasive and indirect approach, to predict embryo outcome and pregnancy outcome. This is another group from UK who suggest by this approach the same concept to identify euploid oocyte and predict pregnancy outcome. So this year we did start participate to mega set study of Ferring, which conducted by Ferring, and we did screening gene expression profile on cumulative cell in total blinded. We using our score and then to send to Ferring office, and then We can see, for example, for this lady, she have had many embryos. Looking this, if you replace this one, we did select megas, as you can, in megaset study, we replaced just one embryo on day 5. And if you take this one, for example, the cumulus score is very high comparing with embryo number 6, the cumulus score is very low. This is for another, for example, in front of this situation, we can recommend single embryo transfer. If you have a medium score of cumulus cells, we can recommend double embryo transfer, or for example, in my country, each couple gets 4 attempts taken in charge by the society. And in this way, when you don't replace fresh embryo, this attempt don't count for the couple. That means if all score is very low, we can cancel fresh embryo replacement. So once again, you can screening, looking for microRNAs in culture medium in which embryo grows. You know, it's total non-invasive approach to select haploid embryo and also to determine mitochondrial DNA and nuclear and genomic DNA. But be careful, relate the contaminations. We will present oral communication in the next ESHRO meeting of Geneva about this subject. So to conclude, finally, a couple of slides about implantation window. We did report many papers from my group, and we did select 13 biomarkers of endometrium receptivity that we did select among 1,012 genes. And we are able today, less 10 hours, to provide for you, this is a patient, and this is positive control, and this is negative control. For example, it's easy to read here. For example, for this patient, we are in implantation window, and for this one, we are not. By using quantitative RT-PCR, we did test our 13 biomarkers in fertile patients and in independent study by sending to colleagues from United States of America. And third, we did check on ex vivo by separating stromal and epithelial endometrium cells. So you can making biopsy by quantitative RT-PCR, and after a standardization, and we applied our algorithm, and we can conclude if the patient is receptive, whatever in natural cycle or in artificial cycle. That means here, if you are, it depends which stage you frozen your embryo on day 3 or on day 5, and we can determine for you which the best timing to replace. So, but it's not enough today to screening in endometrium cell. It's time to go for the second generation of tests by making only just blood, and we are able to tell you what is the best timing to replace this embryo. That means by this way, we can avoid endometrium biopsy. So that means, yes, it's possible by combining cell-free DNA with microRNA in the blood, in follicular fluid, in culture medium in which embryo emerge. We are able to quantify ovarian stress, predictive cause response, and quantify viable embryo, and to predict a pregnancy outcome by quantify cell-free DNA and microRNAs. And here I summarize all tests. I don't believe in each center should be provide all of these tests. Even actually our friend from Chinese using the majority of our tests, I don't believe it's enough to ask the right question and to identify the right approach. You don't need to provide all these tests for your patients. So to conclude, dear friends, dear colleagues, yes, it's possible today in 2017 to subject art, that we say in French, à la carte, to optimize IVF results. Yes, we still need more science. And as Anglophones proverb said, when you are not intelligent like me, I will try to be surrounded by intelligent people that I do like introduce for you my teams. Thank you very much for your attention.